Now, moving on to our second section, that is the Olecranon fracture. In this section, we're discussing the clinical features and pathoanatomy of Olecranon fractures, how to diagnose them, what is the treatment of Olecranon fractures, and associated with what type of complications. Now, coming to the fractures of the Olecranon, as you know, Olecranon forms actually an elbow joint with the distal radius on the medial side. Its Olecranon is actually part of the ulna, where ulna enlarges and forms a joint with the medial side of the distal humerus. Olecranon fractures are divided on the basis of geometry mainly. There could be simple transverse fracture, which may occur as a part of avulsion due to fall on the outstretched hand with the maximum tricep pull, the tricep contracting so much because tricep is attached on the tip of the olecranon. Other are comminuted fractures, which could be due to direct blow to the elbow or fall on the elbow, on the flexed elbow mainly. Mainly there is geometrical, this is one of the type of classification, other is geometrical classification, whether it's an oblique fracture, it's a stellate fracture, it's a comminuted fracture, it's a transverse fracture, depending upon how the fracture lines and geometry is. It's mainly subdivided into displaced, undisplaced, and whether it is subluxation of ulnar humeral joint or not. Mainly on this basis we are classified the Olecranon fractures. Now coming to the further continuing with it, the fractures always enters the elbow joint, usually because it's actually forming the middle side of the distal radial joint, ulnar joint, and now it may damage the articular cartilage. Transverse fractures, usually the tricep epidurosus is intact, especially in the case of tricep fracture in which the triceps actually pull the fracture fragment out. The fragment may be very much displaced, but actually the tricep epidurosus is very much intact. Sometimes what happens is the fracture fragments usually they stay together and they look, at least on the x-ray, are undisplaced. Stress fractures, although rare, but can occur in highly functioning athletes, especially in the case of tennis players. Now coming to the clinical features, if the patient does comes with an injury to olecranon and if there is an associated olecranon fractures, what would be the clinical signs and symptoms of the patient? First and foremost, there is definitely swelling and bruising around the elbow joint. There may be a breach of skin if there is a direct elbow blow, or there may be some bony fragments, open fracture, bony fragments may be coming out of the skin as well. On examination, there will be definitely a gap will be palpable around the elbow joint because there will be a fracture fragment pause over there. Patient will not be able to extend elbow or even against resistance as well, as sometimes if we ask the patient to extend elbow due to fracture, there will be definitely a lot of pain as well. Stress fracture, although rare, but it's a possibility, especially in case of highly functioning athlete. When x-rays look normal, we must rule out the stress fractures. Although stress fractures usually have a very typical history, especially in the case of normal x-rays. Now, once we know that most likely there's a problem around the elbow, then the first and foremost is to get an x-ray of the elbow, that is the AP in the lateral view. If you see it on the lateral view, this is what you're going to see. Now, previously we talked about capitellum, and if you see the ulna is actually the anterior humeral line is passing through it, through the capitellum. But if you see over here, the olecranon is displaced massively and it's not forming a joint with the distal radius. This is actually showing that most likely there is actually a fracture of the olecranon in which there was a transverse fracture along with the comminuted one, and tricep has actually retracted this segment quite and leading to displacement. Lateral view is very important because actually it tells you the detail of it, but we have to get two views, that is the AP and the lateral view. On lateral view, what we have to look for is we have to look for the presence of comminution, degree of displacement, and sign of subluxation of ulnar humeral and radiocapitellar joint. Because subluxation is also important, because if there is subluxed joint or there is displaced joint in form of dislocation, that means the soft tissue injury is also massive, and that has to be taken into account when you're treating the patient. Now coming to the treatment. Treatment is basically initially is analgesia, that the patient can make the patient pain free, and immobilization in form of sling. Now depending upon what type of fracture is actually dictates the treatment. If it's undisplaced transverse fracture that does not separate, and when the elbow is in x-ray is in flexion, that means we can be treated conservatively, and that is without surgery. And we usually go for immobilization of the elbow for, let's suppose, usually 3 to 4 weeks, and we allow the fracture to heal over there along with analgesics and medicines which reduce swelling most of the time. But if the fracture is displaced, then we probably need to fix it. And usually casting is not recommended. Sling and cuff polysling is more than enough for the treatment of undisplaced olecranon fractures. Now coming to the operative repair, that is usually done for if the cases of displaced fracture fragment. Displaced and those with instability of ulnar humeral and radiocapillary joint, because that means we have to go for open adduction internal fixation and have to repair the soft tissue as well. There are multiple methods of fixing the olecranon. There could be in form of plate and screws. This could be using cerclage wire and K wires as well in form of tension band construct. But most of the time, almost plate and screws enough in almost all of the cases, except for simple transverse fracture with a stable joint. Simple transverse fracture with a stable joint can undergo suture repair, which can be used in form of a tension band construct, which usually use K wires and cerclage wires in form of a tension band construct, and that is where actually usually, but transverse fracture is actually rare. Most of the fractures are either oblique or other fractures are comminuted, and we have to go for plated screw fixations. Now coming to the complications, we have surgically fixed olecranon. What could be the wrong or what could be the complication which is associated with the surgery of the olecranon fractures? Usually it's the stiffness, because the patients, if not properly mobilized and rehabilitated, it could lead to non-union after inadequate adduction or fixation, or it could be even stiffness due to non-mobilization. Other is actually ulnar nerve injuries. Although ulnar nerve injury is rare, but if it's a sublux joint, especially associated with the medial humero-ulnar joint, this sublux or dislocated joint, this can lead to ulnar nerve injury at times. If we are using a tension band construct and using K wires, we have to be very careful that those K wires do not protrude out of the ulnar cortex, leading to anterior interosseous nerve injury as well. Other is osteoarthritis. If it was a comminuted fracture and intra-articular involvement was there, even if the maximum effort was done, late complication of usually a comminuted fracture is always some degree of elbow osteoarthritis. That can be either managed with analgesia and activity modification, or if the patient is old age and there is not much of a activity, we can go for total arthroplasty as well. In this section, we briefly covered the fractures around the olecranon. As you know, the olecranon forms actually the joint between the distal humerus on the medial side and the ulna. Fractures are mainly classified on the either two bases, whether they're displaced or undisplaced, or whether they're associated with subluxation or ulnar humeral radiocapillary joint or not. The mainstay of an undisplaced fracture is actually conservative, that is sling and immobilization along with the analgesia. Usually we have to go for operative fixation because mostly they're displaced and comminuted as well. Most of the time they can be treated with plate and screws construct and during open adduction internal fixation, but sometimes simple transverse fractures can be treated with a tension band construct using cerclage wires and K wires. Thank you very much. Keep watching sqadia.com.